All right, welcome. Today, we're diving into the world of medical detectives. You see, getting to the right diagnosis isn't always a straight line. It's really more like detective work. You're gathering clues, spotting patterns, and piecing together a super complex puzzle. Let's get our investigation started.
You know, Voltaire had a point. A lot of the time, the body heals itself. But sometimes, nature throws us a real curveball, one that needs some serious investigative work. So today, we're putting on our detective hats to crack two really challenging clinical cases, and we're only going to use the evidence laid out in front of us.
So here's our game plan. We'll kick things off with the diagnostic challenge itself. Then, we'll jump right into our first case file, a persistent cough. After that, we'll tackle a second mystery involving chronic pain. And finally, we'll wrap up by looking at what both of these puzzles can teach us about the real art of diagnosis. Okay, case file number 1 is officially open. The main complaint is a persistent cough. But as any good detective knows, that initial report, that's just the tip of the iceberg. The real story is always buried in the details.
So our patient is a 54-year-old man, but listen up because this next part is the single most important clue in his entire file. He's a recent renal transplant recipient. This means his immune system is being deliberately held down by medication to stop his body from rejecting the new organ. For a detective, well, this changes everything. It opens the door to a whole lineup of unusual suspects, infections that a healthy immune system would normally just swat away. This is our prime lead.
Let's dig into the symptoms. For 2 weeks now, he's had this dry cough that just won't quit. He's getting more and more short of breath, and he's got a low-grade fever that comes and goes. Now, he's not coughing up blood or having chest pain, which is good. It helps us rule a few things out. But the way these symptoms are getting worse, that's definitely worrying.
The physical exam gives us some hard evidence to work with. He's got a fever, his breathing is fast at 22 breaths a minute, and this is critical. His oxygen saturation is only 91% on room air. That is low. When the doctor listens to his lungs, they hear these fine crackles on both sides. It's clear his lungs are in some serious distress.
And now, the lab work. Take a look at that white blood cell count, the WBC. It's 2.8. The normal range starts at 4.0, so this is way, way below where it should be. This is exactly the confirmation we were looking for. It proves his immune system is suppressed, leaving him vulnerable to all kinds of infections that a healthy person would just fight off without a problem.
The imaging here tells a really powerful story. Both the chest X-ray and the CT scan are showing widespread changes in the lungs. Specifically, that CT scan reveals what's called diffuse ground glass opacities. I want you to picture like a fine, frosted haze just settling over the delicate parts of his lungs. It's a classic sign of widespread inflammation and fluid filling up the air sacs.
And here it is, the smoking gun. Doctors went in and did a procedure called a bronchoalveolar lavage, or BAL. Basically, they wash out a small part of the lung to grab a sample. And that sample? It tested positive for an organism called Pneumocystis jirovecii. We've found our culprit.
So with all the evidence laid out, we've got an immunosuppressed patient, classic symptoms, low oxygen, and a positive lab test. What's the right move? What's the most appropriate initial treatment here? Take a second and think like the clinician on the case. All right, the investigation is officially complete. Time for the big reveal. Let's see how you did and formally close this case.
The correct answer, the right move, is to start intravenous cotrimoxazole. It's a really powerful combination antibiotic, and it's the absolute gold standard for treating this infection. And given how low his oxygen levels were, getting that medicine directly into his bloodstream through an IV is absolutely crucial.
So the final diagnosis is Pneumocystis jirovecii pneumonia, or PGP for short. This is a classic opportunistic infection. It literally seizes the opportunity of a weakened immune system to cause a really severe, life-threatening illness. Our patient was, unfortunately, the textbook example.
And this table right here shows you why precision in medicine is just so important. These other drugs, they're powerful, but they are completely the wrong tool for this specific job. Clarimatrocymon and meropenem, they have no effect on this organism. And itraconazole and voriconazole, they target entirely different types of fungi. For PJP, cotrimoxazole is the one and only correct choice on this list.
Case 1 is closed. But another file has just landed on our desk. This time, the central mystery is chronic abdominal pain. Let's open it up and see what clues we can find.
Okay, right off the bat, we have a major clue. But it's not from a lab test or a scan. It's about where our patient is from. She's a 26-year-old woman who moved from the Philippines just 6 months ago. And as you're about to see, this single piece of information about her background is absolutely vital to cracking this case.
So her symptoms have been going on for 3 weeks. She's got this abdominal pain, a low-grade fever, and what we call classic B symptoms, things like night sweats and losing weight without trying. These are huge systemic signs that the body is fighting some kind of chronic, deep-seated infection or inflammation.
Her lab work paints a really clear picture of chronic inflammation. Her hemoglobin's low, which points to anemia of chronic disease. Her platelets are high, another common reaction to inflammation. And just look at her inflammatory markers, the ESR and CRP, they are sky high. And to top it all off, her Mantic skin test for TB came back positive. That tells us she's been exposed to tuberculosis at some point in her life.
Now let's move to the imaging. The CT scan shows thickening in a very specific part of the intestine, the terminal ileum and cecum, and it also shows necrotic, or basically dying lymph nodes nearby. That's a huge clue. And even better, a sample of fluid from her abdomen shows a really high level of an enzyme called ADA, which is strongly suggestive of tuberculosis. Okay, let's assemble the facts one more time. A young woman from a country where TB is common, chronic inflammatory symptoms, a positive TB skin test, very specific CT findings, and a high ADA level in her abdominal fluid. What do you think is the most likely diagnosis? The picture here is becoming crystal clear, isn't it? All the evidence has been pointing in one specific direction. So let's connect those final dots and make the official call. And the diagnosis is intestinal tuberculosis. Every single clue, from her country of origin to her labs and her imaging, it all fits perfectly. To be really specific, it's the ileocecal type, which affects that exact part of the intestine we saw in her scans.
Now, while some other conditions can look similar, they just don't fit the evidence nearly as well. Crohn's disease can definitely mimic intestinal TB, but that high ADA level and her background make it much less likely. Lymphoma? That wouldn't cause a high ADA. And other infections like amoebiasis or Yersinia, they're usually acute illnesses, not something chronic like this.
So we've solved both cases. Now what? What can we take away from these two very different medical detective stories? What's the common thread that runs through this whole clinician's puzzle?
This is a great way to look at it, comparing our two investigations side by side. For that first case, the PJP, the patient's medical history, his immunosuppression, that was the master key that unlocked the whole thing. But for the second case, the intestinal TB, it was the patient's epidemiology, where she came from, that was the critical starting point. Two different cases, two totally different primary clues, but the exact same detective process.
And this gets to the heart of it all. A diagnosis isn't just a number on a lab report. It's a complete story. It's a narrative that you build by weaving together the hard science of tests and imaging with the uniquely human parts of a patient's life story and, of course, a clinician's own judgment and intuition.
And that leaves us with one final question to think about. After seeing how these two puzzles were solved, what do you think? Is making a diagnosis a pure objective science, or is it a skilled and intuitive art? Or maybe the truth, as it so often is that it's a little bit of both.